Good afternoon, everyone. I'm Ann Waldorf. For those of you who don't know, I'm the vice chair for behavioral sciences here in the department. And it is my great pleasure to introduce a colleague who many of us have had the opportunity to work with over the years, and one of her colleagues who will be presenting today on delivering culturally informed care to increase language access and equity. If I can just take a minute to introduce folks. Dr. MacDonald Wer is a bilingual English-Spanish pediatric neuropsychologist, an assistant professor at the University of Texas Southwestern Medical Center and Children's Medical Center in Dallas. Her clinical focus is on the neuropsychological evaluation of bilingual and monolingual children with a wide variety of neurological and neurodevelopmental disorders, ranging in age from early childhood through late adolescent and including transition planning. She provides clinical services at Children's Health and clinical and research services at My Health, My Resources Autism Program. Dr. MacDonald's research focuses on how to better understand the impact that different factors, such as socioeconomic status, language, and culture, have on neurodevelopment and how it informs culturally competent and neuropsychological practices. She serves on several national and regional boards and initiatives that are focused on increasing healthcare equity, fostering mentorship and sponsorship, and strengthening of student pathways. Dr. Costello is a bilingual English-Spanish pediatric neuropsychologist and assistant professor of neurology at the University of Texas, Austin, and the Dell Medical School. She completes comprehensive neuropsychological evaluations for children, adolescents, and emerging adults with epilepsy who may be candidates for neurosurgery. Dr. Costello also conducts assessments for youth with various other medical conditions, including such things as spina bifida and genetic conditions. Her research currently focuses on health disparities and bilingual brain development in pediatric medical populations. She has presented locally, nationally, and internationally, and is active in several neuropsychology organizations, namely the Hispanic Neuropsychological Association and New to Neuropsychology, with the aim of fostering equity and inclusion for patients, students, and providers alike. Welcome to Dr. MacDonald Wer and to Dr. Costello.
Thank you so much for the introduction, and to see familiar faces, I'll pass it on to Dr. Costello. She'll start us off, but just wanted to, I see some familiar faces and names, so thank you so much. And it's a pleasure to be back virtually and just miss you all. So we will present a little bit of our work today and take questions and answers throughout. Okay, so take it away, Dr. Costello.
Thank you. And do my slides look okay? Showing just the slide, not the notes? All right, great. Thanks, y'all. Okay, so let's get started here. So no financial disclosures or conflicts of interest today, but personal disclosures. Both Dr. MacDonald and I are multilingual and deeply committed to access and equity in healthcare. So we bring those experiences, perspectives, and values to this conversation. So our objectives today are that learners will be able to define bilingualism and how it informs social interactions and communication. We'll want to be able to describe the psychology and culture of language and how it shapes the way individuals think and behave, and then integrate best practices and guidelines for use of interpreters during clinical encounters. So to begin by defining bilingualism, the definition is a very complicated one. So no two bilinguals are exactly alike, and their differences will come to have some significant implications in terms of what we might expect cognitively, neuroanatomically, and psychologically, and proper characterization of bilingualism is essential to informing evaluation and treatment. Some demographics behind bilingualism. So we see that about 50% of the world has bilingual folks, and 20% of US citizens identify as bilingual, with Spanish being the most common second language that we see. 82% of identifying Latine adults speak Spanish, 76% of those are Spanish dominant or bilingual, and 24% are English dominant. In Europe, we see bilingualism being even more prevalent. So in a recent survey, about 56% of the population across all European Union countries reported being functionally bilingual. And then some countries have particularly high rates, like Luxembourg at 99%. So bilinguals obviously make up a significant portion of the population. A little bit behind the history of bilingualism in the United States and how it's been thought of over time. Looking back to the 1920s, we see comments about a foreign language in the home being related to mental retardation as measured by intelligence tests. It doesn't seem to be a stretch to guess that folks who weren't English proficient were probably having their IQ tested in English and with tests that weren't culturally relevant to them. In 1962, we see the first documentation of bilingualism being referred to as an advantage that leads to an increase in mental flexibility. And then in other points in history, bilingualism has been referred to as a handicap. We've seen educators encourage families to focus on English or phase out a heritage language when there are signs of academic struggle or language delays. Are there disadvantages of bilingualism? We sometimes see smaller vocabularies in bilingual individuals if they're only tested in one of their two languages, but they actually tend to have greater vocabularies than monolinguals if they're allowed to, for example, name items in either of their two languages. Bilingual individuals might be slower or less accurate on naming tasks, but we also have to consider the interference of other languages. And bilinguals have shown to have more deficits on verbal fluency tasks, especially in semantic fluency conditions, even if they're able to respond in either language. The advantages of bilingualism, here are a few of what I believe to be many. So there's been some evidence to suggest that bilingual individuals demonstrate better executive control than monolinguals when matched for age and demographic factors. So over the past several years, whether bilinguals might have a unique advantage in the domain of executive functioning has been pretty hotly debated. So in a bilingual individual, that person is constantly having to inhibit one language in order to selectively attend to or activate the language that they're currently using in order to speak and understand fluently and without error. So it's as if they're kind of continuously training that particular executive functioning system. In children, we know that executive control is related to academic achievement, and academic success is known to be a significant predictor of long-term health and well-being. So now that we've discussed some of the history and demographics related to bilingualism, how do we actually define bilingualism or multilingualism? Are all bilinguals alike in terms of their brain development and their ability to navigate two or more languages fluently? Taking a closer look at some of the core defining features of bilingualism and someone's level of bilingualism can help guide decision-making when conducting consults or psychotherapeutic intervention with bilingual or multilingual individuals. So specifically, we'll talk a little bit about the timing of bilingualism, the context in which multiple languages were learned and utilized, and how those aspects inform someone's level of bilingualism. First, let's talk a little bit about timing. So regarding timing, in those with simultaneous acquisition, we're thinking about individuals who pretty evenly learned both of their languages from birth or very early on. So as children, these bilinguals typically tend to meet language milestones at the same time as their monolingual peers. On testing, I mentioned you might see what look to be lags in receptive or expressive vocabulary, but that's really when they're only tested in one of their multiple languages. And then sequential learners, on the other hand, learn one language and then the other, as the name implies. And we can further break that category down to early versus late learners. So in the early category, that person has at least partially acquired a first language, and then they may begin to learn a second language, maybe when entering a pre-kindergarten classroom, emigrating to a new country, for example. And more recently in the literature, there are kind of some varying opinions on what constitutes early versus late. So some folks use a more conservative cutoff of 3 or before the age of 3 being early. And then we've seen some other cutoffs as well, more liberal cutoffs like 5 years, 7 years, or 12 years of age to differentiate between early versus late. So in that late category, we see the second language being a lot more mediated by the first language. So this person is really more likely to be learning the second language more heavily through the lens of the first language in terms of grammar and sentence structure. In terms of context in which languages were learned regarding the home environment, the amount of language used and the level of language used can correlate with the parent's level of education. And other complicating factors might be socioeconomic status that could potentially impact opportunities for language enrichment, not just through verbal conversations, but other aspects of language like reading and being read to as well. Similar consideration should be made for the child's school environment. What is the quality of that person's education, the languages that were used across the years in their educational context. And then I want to talk a little more about BICS and CALP. So BICS represents basic interpersonal communication skills. So this is referring to language that's used in kind of everyday social interactions, like children interacting on a playground, someone ordering at a restaurant, asking for directions, kind of more surface level day-to-day communication, which is obviously very valuable. And research generally suggests that BICS can be achieved within about 2 years of immersion in a second language. And then CALP, on the other hand, refers to cognitive academic language proficiency. So this has to do with the academic use of language, which can be a little bit more abstract or specialized. So we're thinking about the ability to use that language to make comparisons, to synthesize information, or to make inferences. So this would be something that kids would be utilizing more likely in the classroom setting than on the playground. And CALP takes more like 5 to 7 years of immersion to fully master. So here I'll show you some of the terminology that describes a level of proficiency in a given bilingual individual. And I'm not going to go through all of these, but I'll just kind of mention that this is really thought of as a spectrum. So over here on the left side with semi-lingualism or limited bilingualism, that tends to be folks who are pretty limited in resources and literacy in general. And so might be, and when we're talking about bilingualism and literacy, we're thinking about expressive and receptive language in addition to reading and writing. So someone who's semi-lingual might have some proficiencies in 2 languages, but they're not kind of fully mastering either. I think we see receptive bilingualism quite a bit, where someone can understand pretty well 2 languages, but might really only be able to express in 1. And then moving across the spectrum to balanced bilingualism here, that's when we most often see that expressive, receptive reading and writing competencies in both languages. That doesn't mean that they're completely equivalent to one another or that they're both perfect, but kind of multiliterate abilities in both languages. And so we wanted to pause to gather any reflections that you all might have so far in, whether you are bilingual or work with bilingual families or know someone who's bilingual, kind of wondering how this background information resonates with experiences that you've had.
So we welcome folks to unmute, share, or share over the chat if you feel more comfortable over this chat, and I'm happy to read it. Are you bilingual? Do you know someone who's bilingual? Like, what stands out? What's been your experience?
Well, I'll say something. Hi, I'm Debbie. I'm not bilingual. I was married to someone who was bilingual previously, and I had hoped to raise my kids being bilingual, but that's been a little bit of a challenge. I've worked with some patients who have been bilingual. So I actually had a question about sort of, I don't know if it's a common misconception or myth, or if it's based in data, but you know how my former partner who was bilingual was had delayed speech onset, and they sort of joked with this person about how it was because there were so many languages being spoken at home and they didn't know which to speak or how to speak. Is that a common misconception, or is that something that actually, should we be aware of flexibility of developmental milestones based on multiple languages being spoken at home?
Yeah, that's a great question. So I think generally with typical language development, like in someone who doesn't have a language disorder, we tend to see milestones met around the same time. But I think that vocabulary kind of explosion that you sometimes see in development might look a little bit different, especially if it's across multiple languages. Dr. MacDonald, do you have any other thoughts about that?
No, similar, it's if there's a medical condition or if there's, a disability or a disorder, we might see development be different, and they're going to have difficulties in both languages, but they're able to communicate and they're using both. So sometimes it says, like, if you're going with an English speaking provider and it's a bilingual household, they're like, oh, they're not speaking as many words, right? So it really takes the full context. There might be some silent periods, and I experienced this with my daughter, who, same as you were sharing, Debbie, like wanting to embrace her bilingual. When she was put in a full Spanish immersion classroom, there was a silent period about a month of like reduced language. So like there's things, but development typically is very similar. It might not be right, like the expected time frame for a milestone, like let's take walking, right, all the way from 8 months to maybe 15 months, right? So it's a big range of months. So it might take them a little bit longer, but not to the point of, at 4 years of age or 3 years of age saying their first words.
Thank you. I have one other quick misconception. You can tell me it's not relevant and move on. But is it true that you're fully competent in a language when you dream in that language? Is there any truth to that? Is that a marker we should be asking people about or following in any way? Since I'm interested in dreams as well.
That's another great question. I mean, I definitely ask patients when I'm trying to gauge kind of immersion and the frequency that they use each language. What language do they think in? What language do they dream in? I think, I don't know that it's necessarily like a hard marker, like I am now proficient, but I think it is kind of a sign of how much, it's been in your mind during the day, thinking about language in terms of not just even speaking, but what you're hearing, what your stream of consciousness is. If you're having a lot of interactions in a second language and kind of preparing to use that language and, thinking in that language more, then I think you would be more likely to dream in that language. So it is like a nice, I think not like a hard marker, but a nice indication of this language is clearly in this person's mind a lot, and they're kind of approaching that proficiency.
Yeah. Okay. Thank you for sharing. Next slide. I'll just be mindful of time. So thinking about culture and dreams, I think it's a beautiful transition and an example that I was actually going to use, because I work with Spanish and English speaking individuals, but actually learned Italian and was a sequential speaker, a simultaneous learner for English and Spanish, and then sequential for Italian. And I learned it in college. So I actually, in fully immersed experience in Italy, dreamed in 3 languages, to your point, but I don't consider myself proficient in Italian. At that time I was, because I was reading, writing, I was living in the culture. So it really, context does matter, and wanted to really highlight then language and culture and how from a day-to-day practice it informs our experiences. And it really varies. Our proficiency and dominance varies over time, right? So I'll share, I've lived 20 years in one country and 20 years in another country. So my experience in early childhood and adolescence was very different in how I thought about things, conceptualized things, as well as now living in an English-speaking culture, how my memories are formed, my perception and emotionality for certain events vary. So, right, like our immersion experience and thinking about our clients and our patients, right, like what's been their history is really important. So I'll highlight a couple things about language and culture in this section. Next slide, please. So the first one that comes to mind, right, is language emotional, right? Of course, we're going to say yes. And bilinguals often describe their first language as more emotional than their second language. And that, depending on proficiency and fluency and what they're using day to day, may vary. So that, in part of your clinical interviews, is really instrumental to ask. There's been research, for example, I love you carries the strongest emotional weight in L1. And I'll share, for example, te amo, like I love you in Spanish, and I love you carries significant difference for me personally when I say it. The emotional weight and emotional responses to taboo and swear words also in childhood reprimands, right? Like might be stronger in L1 than L2. And that actually has shifted in some of the research. So I'll share some update research on that. as well as how they're perceived by others or perceive their language when they're speaking. Is it more natural? Is it more artificial, right? And that is going to vary depending on fluency. How much am I using it? How balanced, right? Because it's never at the time that you're going to be fully balanced, right? I'm going to read and write the same in both languages and speak and understand in both. There's always going to be variability. So how do individuals feel more comfortable? Next slide. But language overall guides our reasoning about events, how we process the world, and the words that we use to describe experiences, emotions, and events. So when we look at word processing, like emotionality effects of language are not restricted, right? I think there's more research now that is not restricted only to the first language. So, in the previous slide, I talked about swear words and taboos, but now there was updated research in 2019 by Dr. Monica Rosselli and her team. And when they were looking at taboo and negative words, right, like they differentiated taboo and negative, taboo words were perceived to be less powerful in a second language, but negative words were perceived as more negative in that second language. So even just in how we are perceived, right, taboo versus negative words, it's context matters. How much we're using the language matters. Additionally, there's an interaction effect of mood, right? Is the person when they're processing in a positive mood and a negative mood, and their gender also influences how they're going to, the valence that they're going to attribute to the word or the experience, right? Especially in unbalanced bilinguals. And to add a third factor, right, there's lexical proximity. So of the language and how we process emotionality. So if we look at the next slide, I love this picture of looking at the tree of languages and how the proximity, the lexical proximity of languages. So if you think about Spanish, Italian, and English, I may process words in a similar manner when presented in Italian and Spanish, but when I'm code switching between Spanish and English, there's a difference in emotionality in how I'm processing, right? So really considering and thinking about what our client, what our patient is processing and thinking, right? Are we using an interpreter? All of these, but putting at the lexical proximity as well is going to be important. Next slide. So if we speak 1, 2, or more languages and process and describe the world differently in each language, how does an individual perceive themselves in each language? And what assumptions do others make about the individual? So I'm going to share 2 anecdotes to bring the statements in this slide to life. So first, I think when my spouse first met me, all our conversations were in English, since he doesn't speak Spanish. And I do not make, and I didn't make much of this, right? This was over 10 years ago. And I've become more familiar with the research in language and personality and word processing now. And it was only when he saw me interact with someone from Guatemala that he was amazed. He's like, and it was not because I was speaking Spanish. He knew I spoke Spanish, but because I was a different person in the use of my mannerisms, my facial expressions, personality overall. And he shared, it's like, I'm seeing you for the first time, like your full self. And now if you fast forward to the present, I see this a lot when I interview trainees in English and Spanish. So when I'm interviewing for internship or fellowship, I do an interview in both languages if they say that they're bilingual. And I recently interviewed an individual who spoke both English and Spanish, and English was their second language. And, a lot of the interview, it was a group interview. Most of the interviewers spoke English, and he was, like the person was very serious. She was just talking. I was like, it's really hard to gauge their interest. And then I switched to Spanish, and just personality wise, right? Like bright facial expressions, is just their full self came apart. And so my judgment, right? I had to check myself, was very different how I perceived this individual in an interview using their second language versus their first. And I was the only one that had that opportunity of seeing them speak in both. So again, right, the false conclusions that we might make about a person and their personality in one language versus the other. And then this is further amplified often by accents. right? We assume that the person is less proficient or there's limited proficiency, but it's a proof that they're fluent in a second language, right? And they're communicating in this language. So really that as a listener, increasing our patience, right? Like accented speech can take longer for a listener to process, but it's reducing our immediate like bias, right? Or just jumping to conclusions. So thinking about that, because it is really important when we think about, next slide, language and therapy, right? Like so the reason we're sharing about bilingualism, language and culture is to bring to the forefront that the way that bilinguals express themselves and experience life can differ greatly across languages. And the fluency with which a client may process a traumatic event or describe symptoms may be different in one language than another, especially if they're describing this in a second language. So we have to consider the factors listed in this slide and think about how to be mindful and responsive to this, be it an assessment, be it a clinical encounter, be it over the course of psychotherapy, right? And this also applies, right? Like I'm going to bring in and throw in a third situation, right? This also applies when the provider speaks one language, the patient speaks another language, and the interpreter facilitates the encounter between the patient and the provider, right? Like what information is lost in translation? Next slide, please. So we really wanted to focus on the practical recommendations, right? And we want to devote the majority of our presentation to these practices. And because more times than not, our disciplines have limited training in the use of interpreters, right? There's not a formal course on let's use interpreters and translation services. And so how do we integrate language services into clinics, hospitals, and organizations to increase language access? Next slide. So I want us to first reflect, and I'm going to read this question to really take a step back and think about the experience of someone, you know, and yourself potentially, of have you ever been surrounded by people who spoke a language you did not understand, right? Have you ever been unable to communicate directly with a medical provider? Have you ever signed a document written in a language you do not read? Have you ever worried about calling to make a medical appointment due to lack of understanding? Have you ever not understood the doctor's instructions or follow-up care? And has a medical provider ever conducted a procedure you did not fully understand? Right, so both Dr. Costello and I have practiced neuropsychology and continue to do so in unique states where the predicted demographic change that the Hispanic Latinx community will comprise 29% of the US population by 2050 is previewed. And as you are all well familiar with, in New Mexico, we serve a high proportion of individuals and families from culturally and linguistically diverse backgrounds, and that demographic shift is already previewed, right? So we have to actively evaluate and improve our clinics and training and research to increase healthcare access, and a big component of it is language. Next slide, please. So last year, my colleague, Dr. Strutt, and I presented at the same Grand Rounds, so thank you for having me back, on the Salud Strutt MacDonald Equitable Healthcare Model that actually originated, and my portion started at UNM when I was an intern, then a fellow, and then a provider at the Center for Neuropsychological Services. So some of you are all from the same audience, and today we're going to be applying certain components of this model to language access and equity. We will not dive into all of the components, but if you did not attend the previous Grand Rounds, I encourage you to review the recording on the UNM YouTube channel. Next slide, please. So we'll talk about how do we handle language equity, right? We need to take consistent and thoughtful action. And so from the Salud model, we want to highlight these components, right? Have a framework or ground in either, you know, a framework like the Salud model or the class standards that are from the Department of Health, or from whatever discipline, right? But review the literature. I think there's a lot of growing literature on this. If you look at the interpreter literature, way back in like the early 2000s is not as many, but it's grown, especially with the pandemic, as well as looking at clinical service and integration and how do we improve our practice, who do we partner and collaborate with, and quality improvement projects, and how do we actively measure these across our services. So the next deck of slides has on the right top corner the component or components that are being applied from the Salud model. Next slide, please.
Okay, so I want to point out that we've been using the terminology interpreter because we're really referring to the higher level skill of kind of summarizing and synthesizing information in an interpretive way, rather than just directly translating information word for word. So when we're working with trained interpreters in a medical setting, interpreter is typically the preferred word to use rather than translator. There's also a difference between proximate and remote interpreting. So proximate refers to in-person interpreters and comes with a special set of considerations, like how you arrange seating beforehand, how you orient your verbal communication and your nonverbal communication towards the patient rather than towards the interpreter, even though the interpreter is the one who's more immediately understanding what you're saying. So that can feel a little bit unnatural at first. And then remote interpreters, of course, are those who either join a session via telehealth platforms or who may join, via an iPad or another remote system while you are in person with the patient. Interpreters can both facilitate communication and better the understanding of a patient's symptoms, but can also increase the risk of error in communication. So untrained interpreters in a medical setting misinterpreted or omitted up to 50% of physicians' questions in this first study. And then trained interpreters even still make errors. So in this study in a pediatric ER, Spanish language interpreters made an average of 31 errors per patient, and 67% of those errors potentially impacted diagnosis or treatment. So this really stresses the importance of pre-session briefings and post-session debriefings. So in the pre-session, you want to be, letting the interpreter know, giving them kind of a heads up of what kinds of questions you're going to be asking, might give them an opportunity. They don't know every single word under the sun. So especially if you're kind of trying to gauge a medical diagnosis, there might be some words that they want to double check and make sure that they can just maximize their accuracy. And at the same time, if we're thinking about things like therapy or a situation where you might be delivering a diagnosis that's going to be challenging for the patient to hear, it can be really helpful to kind of coach the interpreter beforehand so that they're not blindsided in the session. Have been in sessions before where even with the pre-brief that interpreters have become tearful. And so I think that that's helpful for them. And then post-session, touching base with them about any observations that they may have had, whether it was about the patient's use of language, whether their presentation was more culturally normative, if they share a culture with the patient, which we'll talk about in a little bit. And then there are some ethical considerations as well. So really want to see careful monitoring of understanding regarding consent for treatment, limits of confidentiality and confidentiality with the interpreter involved. So just reviewing that with the interpreter, ideally beforehand, and making sure that the patient has room for questions if they have them. So interpreters can also take on different roles in the medical setting or in the context of a session. So one common role is that of regulating turn taking. In this role, interpreters use techniques like interjection, which they might cue the patient or provider to please pause what they're saying so that the interpreter has a moment to interpret. Different interpreters definitely have different working memory capacities for how much they can kind of maintain in mind before some of that information is lost. And like we said, we want to eliminate as much error as possible. So interpreters might serve to cue the patient when to pause or please respond to a question that has been asked. Sometimes interpreters take on the role of cultural broker, in which they serve as a bridge between the patient and the provider, or facilitate the provider's understanding of what might be normative in a given culture. It's important that we don't assume that a patient and interpreter share a common cultural background just because they share a heritage language. But sometimes interpreters can provide really valuable insights into what symptom expressions or beliefs or behaviors might be normative for a culture. And then providers, always encouraged, should still be continuing their own cultural competency journeys, doing your own reading and research, consulting with others when it's appropriate, but interpreters' experiences can often kind of point us in the right direction about where to start. The role of gatekeeper could potentially be a problematic one. So interpreters may at times respond on behalf of the patient, maybe because they assume they know what the patient's answer will be because of something the patient said earlier, or because of cultural context. So again, that pre-session meeting is really essential for stressing that all communication be interpreted and that the interpreter not speak on behalf of the patient. And then there's the role of advocate, and that could refer to the interpreter's advocacy on behalf of the provider or the patient. So an example of this could be the interpreter pressuring the patient to respond or to elaborate on a sensitive subject in a way that the provider didn't prompt and that maybe the provider wouldn't have felt was therapeutically warranted and wouldn't have done themselves. So again, that kind of, pre-coaching about boundaries so that boundaries aren't blurred where they don't necessarily need to be. I want to talk a little bit about interpreter roles and other potential challenges. So to dual relationships in general, in therapy, we're really encouraged to avoid dual relationships where we can. So we wouldn't treat the child of a friend or a colleague. But in the context of psychotherapy, when an interpreter is used, it seems to make sense. And so far, literature has showed that patients typically prefer or are most comfortable sharing personal mental health information if the same interpreter is used to session to session. So obviously this is referring to ongoing psychotherapy. But at the same time, how might the patients aligning with the interpreter present a dual relationship? Does this potentially blur boundaries? And how can we expect for interpreters to uphold the same professional boundaries that we as providers uphold? In addition to sharing the language between interpreter and patient, what if the patient and interpreter bond over a shared cultural community as mentioned in that cultural broker role? Or what if the community is such a niche one that the interpreter and the patient regularly cross paths outside of therapy in a way that's unavoidable? So these authors have made some recommendations around psychoeducation for interpreters. So much like we might share with a patient the limits of confidentiality at the outset of therapy, it's recommended to educate interpreters about subjects like transference and countertransference and the value of boundaries. A second perceived difficulty is the transition of the typical two-person relationship in therapy to a more dynamic or triadic relationship. As the therapist, it can be challenging to monitor reactions to the patient's communication when there's a delay between what the patient is saying and your ability to comprehend that communication. And there might also be a power differential when you experience that delay, but the interpreter does not. So this could definitely feel isolating as a provider. And these authors had recommended actively addressing this triadic relationship and intentionally cultivating it in a healthy way. This can be done by kind of outlining those roles at the outset, encouraging open communication and trust, and valuing each member's expertise. So the interpreter is a wonderful expert in being able to navigate and manage two languages, but the provider is the expert in kind of delivering the intervention and doing the clinical interviewing and those types of pieces. So third, just like therapists are at risk for burnout, interpreters are at risk as well. It's recommended to provide some psychoeducation to interpreters around self-care that can be done in those debriefing sessions, giving them a space to process what's been talked about. It seems intuitive, interpreters are not only exposed to the information that might be potentially triggering in a session, but they're repeating it in the first person as they're interpreting it. So it seems a little bit easier to potentially over-identify with the patient, and especially if there are unique cultural aspects at play as well. So they're certainly at risk for things like compassion fatigue. And then psychologists and psychiatrists need to continually examine their own beliefs and assumptions about cultural factors and linguistic diversity. So we talked about how interpreters, through that cultural broker status, can provide really extremely valuable insight into the patient's beliefs and values, but we don't want to rely on them entirely. We want to be catalyzing our own growth and our own knowledge in these areas. And not, again, assume that they share the same background, the same religion, the same values, the same beliefs, just because they share a heritage language. And then to termination can be emotionally challenging for both the patient and provider, and interpreters are not exempt from that. So it's recommended to prepare them ahead of time, give them the similar timeline that you would give to the patient, give them time to process and prepare, have an increase in debriefing sessions before termination. And in some instances, if you deem it, with your clinical judgment appropriate, allowing the interpreter to process some of those difficulties with the patient in a session. We would do a pre-session before having them do that. So informal interpretation, there are some instances in which more informal interpretation, like using a family member or a community member, to interpret is necessary or appropriate. So especially in more remote or rural areas, or in crisis or emergency situations, in general, it's strongly recommended not to rely on family members of interpreters when you can afford not to. So I recently had a patient who was bilingual Spanish-English and whose mother was Spanish-speaking only, and came to find that in a separate medical system, not the one that I work in, that adolescent patient who ultimately had an IQ of 77, as well as some pretty significant symptoms of depression that she was hiding from her mother, had been utilized as an interpreter for her mother in neurology appointments for years. So it's also common for bilingual children who are continually called upon to translate for their parents to experience a lot of anxiety or frustration in that role. And so whenever we have the access to a professional interpreter, we should utilize that resource.
Thank you. So given the literature and the clinical services and recommendations reviewed, how can we take that literature and be applied and integrated into clinical practice to deliver and to be delivered and increase language access? So oftentimes a needs assessment is necessary, right? And really taking a step back and thinking about ways to improve the experience of patients and reduce single provider tax and burnout. So look at the day-to-day practices, systems, processes, and what are the red flags that pop up, right? If you're reflecting, and when you think about the patient's experience from A to Z, right? Like from when they pick up the phone to when they receive documentation, terminate therapy, or are discharged from services, right? Like what is their experience? Especially, in New Mexico, where over 5 languages are spoken just from the communities, the Hispanic, the New Mexican, and the Native American community. Next slide, please. So over the course of my career, these are the themes, tools, and processes that have come up when staff, faculty, providers, trainees, and patients are surveyed, or we have meetings and discuss, right? So having multi-staff and providers, or having just a language service when you call in and be able to speak in that language and have a third person in the phone, but it's just easy and it's a setup process, right? Having forms and questionnaires in multiple languages, different providers, right? Audio, video, in-person providers. And this really, during the pandemic, became very needed for us. At the hospital where I worked at the time, contract interpreters or contract workers were not allowed to come into the hospital during the initial part of the pandemic. So a lot of the interpreters that we used had to be audio or audio video because they couldn't come into the facilities due to the safety, right? So really having different options. Translation services for documentation. During my time at UNM, it was great. Like our patients received, at least in Spanish, not in other languages, a summary of our services and recommendations, right? So having that embedded just as part of the practice, having those partnerships with language services and knowing the interpreters, and so that you're not having to debrief or introduce every single time to what you're doing, right? So is there a set of interpreters that work clinically with a program within a hospital? Scheduling and requesting interpreters, and how does that work in your clinic, right? It varies by clinic to clinic, so really taking a step back. And both Dr. Costello and I are neuropsychologists, right? So do you have the measures and the instruments necessary to serve your populations? And if not, what measures are you taking? So one of the big things that have come up for both Dr. Costello and I was like, how do we triage and how do we get the patients that really need to be seen by a bilingual provider and not, right? So over the course of the last 3 years, and I'll pass it over to Dr. Costello so she can talk about what we developed.
Sure. So, I think often in the literature and in trying to triage patients, there's not a great consistency in operationalizing bilingualism. We talked about how there's so much variability from bilingual to bilingual. in regards to, the timing of their languages learned, the context they learn those languages in, the level of immersion they've had. So one bilingual is not a bilingual, is not a bilingual. They will have a lot of variability that impacts their emotional processing as well as their cognitive skills. So in order to better collect that data and kind of operationalize bilingualism from person to person, we created this Habits, Acculturation, Bilingualism, Language, and Academic Survey, or ABLAS, really meant to guide decision-making, primarily for right now in a neuropsychology setting, where we have to make decisions about what language should this patient be tested in, which provider should they see. And so ABLAS gathers a lot of really detailed information about those very aspects of bilingualism that I talked about, looking at languages spoken in the home, languages spoken in other social settings, gauging writing and reading abilities in each language, and really anchored around those critical time periods, and really kind of tailored and specific questions rather than just asking a parent, does this child speak English, or are they English proficient enough to do therapy or to do an evaluation, kind of going time period by time period. So just a quick sample here. We primarily work with children and adolescents. And so I think it would be difficult to probably gain this level of detail from an adult where they don't necessarily have a parent or a caregiver present to give this historical information. But hopefully this kind of sets the framework around how to interview around those details of time and level and context. I'm going to move forward here. Dr. MacDonald, I'll pass it back to you.
So, if you do have a screener, or you have a practice of like a formalized questionnaire or questions that, schedulers are using, and you do arrive to the conclusion that, a client, a patient would really benefit from services in a language that, are not spoken by the provider, or increasing the team, right? Like, what are best practices for utilizing those interpreters? Next slide, please. And I think Dr. Costello has gone through, in reviewing the clinical literature, a lot through these, but, scheduling and confirming interpreters, I've definitely had where we've had to fine tune the process. The interpreter doesn't show up, right? And then we can't see the patient, right? So like, how is quality assurance in that process improved over time, as well as what are the qualifications of the interpreters, right? Like, I've had, for example, a specific, doesn't happen as often in Spanish, but in, for example, specific language in the Middle East, and depending on the region within the country, that dialect, right, might change. So yes, it is an interpreter that speaks this language, but they're from a different, right, like opposite parts of the country. So the word and the verbiage might be different, right? So really all of those considerations, as well as, for example, is a male interpreter, right? If it's mom and a female patient and they're the ones coming, can a male interpreter be in the room, right? Especially if we're going to be doing testing. So all of those, thinking about who the patient is, what are the language considerations that we need, and doing that preparation beforehand, as well as discussing what observations to document, right? Like, the interpreter is your eyes, your ears, and that cultural broker, right? In reports, I've read a lot of notes when then I see someone who's bilingual and they had an assessment and there's no documentation of an interpreter was used, right? Like, was the provider English speaking, or Spanish speaking, or Italian speaking? Like, what were the language qualifications of the team that saw this patient, or for therapy services, right? So the next slide gives an example, and this was recently published by a group of colleagues that do have fellowship programs across the country and train bilingual neuropsychologists. And like, how do we document all of this information in our reports, in our notes? Because it is essential for continuation of care over time, right? And especially relevant if it's an assessment and we're doing a reevaluation. Next slide. So, in thinking about having an interpreter in the room, right? And it's we've covered how to improve the practice, how to integrate an interpreter, but how does this play into our therapy and assessment setting? And the message I often hear from patients is that their encounter was brief and rushed, right? Because there was an interpreter in the room. Or from providers, the message is that using an interpreter just takes too much time. So clinical care or interviews are cut short or are briefer. And And I see this oftentimes also when I serve as the interpreter, when I'm doing training with a resident or an intern or a fellow, where even the questions and the complexity of questions gets reduced, right? So how, if we're being efficient, at what cost, and how do we intentionally integrate questions to build that alliance and rapport? Next slide, please. So here are some, considerations on how to build and connect that conversation, right? And how to build that connection and conversation, because, the message often is used in acculturation measure. And we recently with Luis Medina, Dr. Medina and colleagues reviewed all of that acculturation literature. And there's a lot of big gaps and holes on this literature and what is valid and appropriate to ask. So we came up with themes and to really think about how do we weave it into the conversation, right? Not from the first interview that you're meeting the person, but really just weave it into your interview to really get to know the patient, get to know the family, where they're coming from, what their fluency and background, and just as a whole the individual is, and because it changes over time, right? So we were talking about even just the fluency and language dominance of an individual changes over time. The next slide capture this, right? Acculturation changes over time, right? So what are things that are antecedents, and what are we bringing to the table as a provider, as a patient, as well as the current behaviors or past behaviors or future behaviors, and changes over time. So acculturation is not a static definition or process. So in a therapeutic process, in a clinical interview, in a medical encounter, right, it's a snapshot or over a short period of time. So really thinking about multi-generational aspects of acculturation, and then the growth of the individual in a therapeutic setting. So I think if we weave these questions and just, from an open, aware, just curious perspective of getting to know the individual, the patient, the family, it builds that alliance regardless of having an interpreter in the room. Next slide, and I'll pass it on to you, Dr. Costello, to wrap us up.
I know we're running short on time, so I'll go really breeze through these next few slides. So yet another consideration to care. I think early pandemic, it sort of felt like we were launched into the air and had to start constructing a plane for ourselves mid-flight. So now we've all likely gained some level of comfort with utilizing telehealth and telemedicine platforms. And there is some updated literature about best practices, benefits, and potential barriers to telehealth's advantages. So in theory, it really seems that a virtual platform would result in significantly better access to healthcare for more marginalized populations, for folks who don't have reliable transportation, who live in rural areas, who can't take an entire day off work for a medical appointment, whose disability status might prevent them from traveling with ease, whose culture might stigmatize mental health and prevent them from wanting to seek psychiatric or psychological care in a clinic, and for a lot of others, as well as you might have difficulty getting an in-person interpreter, but maybe you can access one remotely via telehealth, and give more linguistic access that way. So in-home care through telehealth might feel like a safer, more private alternative to traveling to clinic. So before we talk about some of the potential barriers that have been noted in the literature in the past couple of years, I think I'll save that for the very end. I was going to ask about some of your particular experiences, but let me just get through the barriers really quickly. So in reality, we see all these potential benefits in this increased access, but what about limited health literacy, limited tech literacy? Older adults, for example, might have some of the greatest difficulty traveling. They might have to rely on others for transportation. They're the very type of individual that we would hope would benefit from virtual services, but they're more likely to have significantly limited tech accuracy that results in lower usage of telehealth. So what's been described as sort of this digital divide, or a new type of barrier or obstacle to care. And those who are savvy in navigating computers or new meeting platforms are able to access telehealth, and those who are not remain reliant on others in some regard. And then we've also seen that actual use of telehealth varies by language. So even if there's an interpreter available by telehealth, if there aren't written materials, for example, that can kind of coach someone through how to set up the telehealth platform, how to access it, if there aren't written materials available in that person's language, then they might be less likely to kind of move forward and more reliant on somebody else. So some of the take-home points today: bilingualism is, of course, a very complex construct. Language goes well beyond speech and words. It's very much embedded in culture, and it is that intersection of bilingualism and biculturalism that influences how we perceive the world and how we process our experiences. Increasing access to healthcare by improving language services in an intentional, programmatic, and is an intentional, programmatic, and daily practice in healthcare. And we have to be, kind of ongoing and with it. It's not something that just comes to be. And lastly, cultivating the therapeutic alliance in a dynamic relationship with a patient and an interpreter and a provider is not impossible, but requires really thoughtful integration of cultural humility, navigation of language skills, and implementation of our clinical skills. Okay, let's stop there and allow a few minutes for questions.
Dr. MacDonald, Dr. Costello, thank you so much. Such important work and very, very applicable to those of us in New Mexico, as well as you in Texas. Folks, I realize we're 6 minutes before the hour, so if people need to pop off, they can, but we're open for questions. Either put them in the chat or just unmute if you would, please.
Thank you, Silva Sarmiento. So good to see you. And thank you, Gabby, for the feedback.
You were so incredibly thorough. No one has questions. As always, Dr. MacDonald.
Exactly, right? Especially on a Friday afternoon. I appreciate like the attendance.
Right after lunch, okay? I'm just telling you.
Right? I know, absolutely.
Well,
Absolutely.
maybe we can get you back next year with more data and more applicability and getting a little away from telehealth, but when it still works. So I just want to say on behalf of the faculty here at the department, thank you so much for spending your afternoon with us. And Robin, anything I'm leaving out?
No, I think you covered it all.
I don't know if you see Dr. Pence's comment that she oftentimes had to serve as her mom's interpreter as a kid. Yeah, really.
No, it was my experience as well, and it's more times an experience. And I often, when giving this presentation, things like, well, it might be common knowledge in terms of like all these practices, but it's not taught. Like I have to teach and one of the things that comes up when I'm being the interpreter for my trainees is a lot of idioms are used. And I'm like, I can't translate that. So it's like, how do we explain something so that the interpreter can effectively interpret and not make errors when we don't use analogies that don't translate, right? Or idioms. So that's a big one as well. So the pressure on children then to do that is just so hard.
Right.
Thank you all so much.
Yes, thank you. Really appreciate it. Enjoy the rest of your afternoon. Have a great weekend, everybody.
You too. Thank you, everybody.
Thanks, everyone.